Let's discuss the last part of change of visual function with age. So in this part, sensitivity and visual threshold. I have tell you many times that threshold increases, which means sensitivity decreases with the time. With the time, it means basically in older patients. So, what are the factors that responsible for decreasing pupillary aperture size basically, which results in illumination decreasing and decreasing number of photoreceptors is neurological factor, isn't it? So, other aging changes in retina results in reduction in availability and regeneration capacity of photoreceptors. That's also important. That's why even it will cause dark changes in dark adaptation curve on dark adaptation process. So this tested measurement change in visual threshold and the function of time spent in darkness. So dark adaptation is also changes. So it is the time dependent increase in visual sensitivity that occurs in dark. Basically, when you expose from light to dark, then how much time it will take to gain that um dark adaptation. So due to the meiosis in lens growth, it will cause problem in the dark adaptation too. So numerous studies have done, but what that studies reveals is a fundamental information that changes in rod and cones creates the dark adaptation problem, and both rod and cones portion of the functions are affected in definitely older patients. So mechanism underlying this change is adaptation in elderly may be both neural and optical. So but there is both component, is it? Neural and optical component. So optical and neural component both. So scopic sensitivity also decreases, like 0.5 log unit decrease with age. So basically, it's basically decreasing in case of um, older patient. Glare, yes, definitely increase because of scattering too. So scattering of the external light within the uh, eye that casts the hazy film over the retina and reduces the image quality. So elderly patients are more sensitive to glare than younger patients. So there are three types of glare as we have discussed: disability glare, discomfort glare, and the specular glare. Disability glare means one of the reasons of disability glare you have to understand is the ocular media itself causes the scattering of light and which causes disability glare. Discomfort glare means the background illumination has much more strong light than the actual retina adapted, which is commonly found in patient with driving, person with driving in night, and all of a sudden light, focused light from the another vehicle come to your face. So that's the discomfort glare. Specular glare is a patchy and bright light reflected from the smooth or shiny surface, which is commonly seen in snow and ices. So yes, photosynthesis recovery test is also one of the good tests, and there are very much tests found in glare, but we're not going to discuss about it. So binocular vision and ocular motility, there is definitely a problem with that. So basically, in my reference books, 27% of the patients with 60s have binocular vision problem, but 38% it definitely increases 38% at the age of 80s. So what are the common difficulties that patient say one is presbyopia, isn't it? Another is with increasing age, increased chances of exotropia. So tonic versions increases and the with the distance, and there is a problem with positive fusional versions, but negative fusional versions remains same. So accommodation definitely decreases, and I don't know about ACV ratio increases or not. ACV ratio I think most probably throughout the life remains constant. Stereopsis, yes, decreases, but a little bit, not like huge like accommodation. The range of voluntary eye movement becomes limited. So, especially in supraduction gaze, the li- movement of eye limited. Okay. So, dynamic visual acuity and motion perception. So, sensitivity to the temporal modulation decreases with age for the temporal frequencies. So ability to detect the motion as measured by the minimum displacement threshold diminishes with age. It's very important to understand. Okay, dynamic visual acuity basically decreases and motion perception decreases. So decline in dynamic visual acuity, target visual acuity with increase in age, and decrease second movement also decreases. Just one of the important thing, but not about second, not about decrease duration and the velocity are less to extent it's affected. But one of the great affected thing in second vision is increased latency of onset with the older patient. Okay, increase in latency on onset is very high in older patient, but duration velocity yes affected but lesser extent. So older people also exhibit significant slower smooth pursuit movement, especially target moving greater than 10 degrees per second. And there is also decrease in ability to resolve detail from moving stimulus. Okay, that's basically dynamic visual acuity. So the management, I'll just go grossly about management. Okay, progressive glasses, ARC, single vision glasses, and there are tinted glasses. There are a lot of things. So ARC, I think it's the best thing we have to do because it will reduce the light reflection from the glasses and help in the glare, a reduction of glare. Okay, yellow tint basically block out the blue rays, and also it enhance some case in night vision. Photochromatic is best thing because it will absorb 100% of UVB and it will protect the inner structure of eye, even retina. And it will definitely soothe the eye in bright light. So UV tint is very important because it will reduce the chances of cataract and the macular degeneration. So basically, it's very good for older patient. So some advice are very good. What are the advice? Using more light because in night especially because of the all those things that going on. So with older patient needs more light and substitute incandescent for the fluorescent light. Reduce driving speed, which is another very good advice. Avoid looking directly at the headlight of oncoming vehicles at night. So that's very good. Otherwise, glare will cause severe accident and other problems too. So closing one eye in the presence of momentary glare, which is helpful to the older patient. Okay, so I think that's it. These are three are my references. You can see some data I have presented there. So I think Bistan choose.